I see a few names that I know, and there's a number of you that I may have not met. So nice to meet you online. My name is Roland Laudenberg, and I serve as the epidemiologist for the Substance Abuse Epidemiological Outcomes Work Group. Quite a name. This group is part of a required activity underneath the Partnerships for Success grant that is supported by the Center for Substance Abuse Prevention. Just to give a little bit of a history, this project and working with the data actually started in about 2005 or 6. It's getting to be a long time ago, 7 maybe, 8, I can't remember, sometime in there. And Center for Substance Abuse Prevention put out, they wanted all states to develop kind of an epidemiological approach and some capacity to look at the data for their state regarding substance abuse related consumption and consequences patterns within the whole population. So I assisted the state, and they reached out to me and assisted the state in putting together a grant and an application to start the SEOW. And then after we had that going for a year, the state received the SPIF-SIG, which was the precursor grant to the current Partnerships for Success grant. Now, Partnerships for Success grant is in its last and final stage right now. And so it's uncertain as to what's going to happen with the epidemiological portion of this long term, but we're kind of in a little bit of a transition, and there's a lot of unknown issues out there right now. But so that's just a bit of history, a bit on myself. I'm originally from South Dakota, grew up on a farm outside of Mitchell, and went to University of South Dakota for a while, then finished at the University of Maryland, and I began working in DC in this area, looking at substance abuse related issues. And many of the projects you work on at the state level and the funding that comes through the state level, I worked on from a national perspective on their precursors when I was in DC. I came back and I finished my master's degree at the University of Michigan School of Public Health. And then I did my EDS work at the University of South Dakota. So I'm kind of an odd duck in terms of I have a very strong biological, physiology base, and then I have the public health and statistics side of things, and the research and kind of human behavior piece through my EDS work. So it's put all that together, it allows me to really look at what's happening with data and what's that mean from the biological side, from the public health perspective, and how do we address it, as well as from individuals that, how do they best learn and change behavior in the long run. So, and I try to use, and my organization, we look at data to try to help our clients really focus in their activities, to really focus in what's the best way to create change in their population that they're serving, to address those underlying issues and create that long-term behavior change. So, okay, now why is my screen not changing? There we go. All right, so hopefully you can read this. Substance abuse, alcohol, is a significant issue within our state. Substance abuse as a whole, alcohol is the primary substance that's being abused. And so I just have this picture here, and thought it was very interesting. This was on my way to work one morning. Actually, I was going to a meeting, kind of actually related to the same kinds of stuff we're talking about this morning. And I was taking a different county road and went through a small town. And here we see Michelob Ultra was sponsoring the annual rummage sale for this small community. They provide the advertisement, etc. It just kind of shows a culture of how connected we are to alcohol within our community. Here's another one. Does anybody see any little bit of issue with this particular sign? Anybody that phrase "food, fun, beer for the whole family." I'm just wondering how many people actually looked at this sign previously and before it was actually printed, and didn't kind of see kind of the nuances of that phrasing. But it's just kind of one of the things that we have to think about in prevention is how is all of this affecting our populations in terms of their substance use, their substance consumption patterns and behaviors.
Yeah, Roland, in the chat box, we did have some people that noticed that.
Okay.
Beer for the whole.
Great.
Yeah.
Thanks. Yeah, on my screen, I don't have the chat box popping up since I have the
pop up if you want, but that's okay. I can just pop in and let you know.
Yeah, chime in, would you please, Dodie? Because then I can, yeah. So one of the things that I like to use this slide, and people that know me know I've used this probably for 20 years now. I've been using this slide. And this is really what we're trying to do with data. We're trying to understand with data, what are the differences between our perceptions and reality? And sometimes we may not really understand what's happening around us because our perceptions may not be aligned with actual reality and the data. And so really what we're trying to do is tease that out and figure out what is really happening and how do we really need to focus our efforts and attention. So just a little bit of purpose. What we want to do with our data and with epidemiology is to look at the who, what, where, when, and why, and how of a disease. So, how often is it occurring? What are the impacts of that particular disease? And in this case, what are the impacts of substance use? What are the impacts of, the new thing that's on the that's really affecting us over the last few years, infecting our youth is e-cigarettes and Juuls and some of the other products that are out there now in relationship to e-cigarettes. What about the alcohol drinks? What's going to happen in regards to marijuana and the push to legalize hemp and all those kinds of things? So understanding the impacts of all of those different pieces is important. And what are the causes or risk factors that puts our population, our individuals at target at risk for adverse consequences from the use of substances and all the other factors that come along with heavy use of alcohol or poor decisions around alcohol use, marijuana use, opioid use, etc. All of those pieces. What are the underlying reasons why somebody might use a prescription in a manner that it's not intended for? So the other thing, just a little bit on the disease process. You have pre-pathogenesis, and some of that is, before disease actually happens, or kind of manifests itself. What makes individuals susceptible? What's their susceptibility to heavy use of alcohol? Is it access? Is it peer pressure when they're young? Is it mental health related issues or stress in their lives, or what might it be? And then what's their ability to adapt or their resiliency to be able to adapt to their situation and be able to use, say, substances in a healthy manner, or their ability, maybe they lack that resiliency ability, and therefore they actually develop more of a substance abuse disease or diagnosis, etc. So kind of thinking through those things, what leads, what are the steps along that path? What are some things we can do to help people use in a healthy manner long term? And then once you get into actually where you do have the disease presence, or in this case where there is a level of substance abuse that is either dependence or abuse, etc., there is two issues to really consider. First, you have individuals where you're not actually able to identify them very easily. They may have the disease, but there are no symptoms. From the alcoholic's perspective, or from the alcohol use perspective, you may hear the term functioning alcoholic. And I've heard that from some people I've worked with that are in the treatment and recovery field. And so they may only have symptoms when they're using, et cetera. They may not have any other symptoms in their lifetime. They may not have a DUI or other consequences from their substance abuse at that point. But so sometimes it's hard to kind of figure out, is there really abuse going on, or is there a diagnosis in place? Then there are the situations in when it can be clinically, you can clinically detect the disease, or you're able to identify the disease or the substance abuse patterns very directly. And I think all of you can probably think of some situations in which that's the case. So just a little bit about statistics that to kind of keep in mind. First, I want to just talk a little bit about associations and correlations. So from much of the data that we're able to pull through prevention and population-based, we can look at associations and correlations. This doesn't necessarily prove cause and effect, but it means that there is a high linkage between that particular indicator and, say, an outcome or substance use, et cetera. And so correlation, the catchphrase is correlation does not mean causation, but they occur together. Very high likelihood. This is very useful in terms of, we know that there's a high likelihood of individuals that use marijuana at a young age, and later some mental health related concerns. So there's a high correlation there. It's not causal, because not every individual that used marijuana heavily at a young age has mental health symptoms later on, but there's a high correlation, a high probability, or there's quite a few individuals that did use at a high age that have mental health issues later on in their life. That's correlation, association, that's what that is. Causal relationships are direct causal relationships. So if I do this, this will happen. And there are some indirect causal relationships that, okay, if I do, if I drink alcohol on a regular basis, eventually it's going to affect my liver. And then later on, my liver may not work very well, and I may actually have cirrhosis of the liver later on. And so what's happening there is the alcohol is affecting the liver, causing that change, and then eventually in the long term there, you're having cirrhosis issues. And ironically, there was just a article that came out, I believe, yesterday in the Argus. I just saw a quick blip on it. I didn't have a chance to read it. They identified that South Dakota has high rates of liver disease, and I don't know. We've been talking about that for years within our prevention network. So that's one of the things when you look at our data, we are very high compared to our substantially higher than our national peers, our counterparts. So what's the challenge? So the big challenge is, how do we identify those individuals in our population, that'd be our target population, who we're trying to reach or serve, who have the disease, and I probably should have put that in quotes, because substance abuse, it's kind of a continuum of a disease, if you want to call it that way, or behaviors, and those who do not have the disease or the behaviors. So, it's really trying to figure out who do we need to target, and for those people that are at the most risk in our population, how do we best address that issue through prevention activities? What's going to be the most effective in reducing alcohol consumption, or making alcohol available, or the access to alcohol for our youth? Maybe it's community norms in terms of, that proverbial rite of passage for youth, that it's okay for them to be using alcohol. all those different things come into play and have to be kind of taken into consideration as to how do we best target and create change within our communities and our target population. Okay, so there must be a way to screen or separate populations of people with and without the disease, and this is with and without substance abuse behaviors or alcohol consumption behaviors or marijuana behaviors. In some manner, how do we figure out within our population who is those individuals that may benefit from kind of more indicated prevention activities, that being prevention activities that are really targeted at those who are actually engaged in the risky behavior of substance use or in the behavior use, et cetera, or consumption of alcohol or other substances. And so, we really have two segments of our population: the whole population, those that are susceptible or at risk, and those that are actually engaged in using the substance. Just a little bit about kind of assessments and screening and instruments. So first, we want to use an instrument that is reliable. And that means that instrument will reliably generate the same result underneath similar conditions over and over and over and over again. We also need to use an instrument that is valid. That means that it is measuring or that is identifying what it is intended to identify. So we want to use instruments that are valid for identifying individuals that are susceptible to substance use. Might be one thing we're interested in. And this is where you get into some sensitivity and specificity. And sensitivity is the definition is just the ability to test of a test or of an assessment to correctly identify a disease or identify substance use in this case. And specificity is the ability to identify correctly those who are not at risk of substance use. So it's within validity, you kind of have a whole host of things you need to think about. But, an example of a reliable instrument but isn't valid would be, think about a clock that is broken or a thermometer. I'll use this one. A thermometer, I have a vehicle where my thermometer consistently reads about 5 to 6 degrees hotter than it truly is outside. That temperature gauge on my vehicle it's reliable because it consistently measures the temperature reliably, but it's not valid because it's not giving you the valid result or the actual temperature that it really truly is. So you can have instruments that are reliable but are not valid because it's not actually giving you the true value. So just a little bit of something to think about when you look at assessments or you're considering to use different assessments or tests or questionnaires. Oftentimes they'll have a little bit of discussion on some research that's been done on how reliable an instrument is and how valid an instrument is. And I think it's important just to kind of at least skim over that so you see that, okay, they are saying it is very reliable and they're saying it is very valid. Okay, so what are the data sources that we look at and we can use to kind of help us understand what's going on in regards to substance abuse, consumption, and consequence patterns in our state and in our communities? And it gets a bit challenging when we start to get to community level, but I'm just going to start with the main data sources that we use. The first is the Behavioral Risk Factor Surveillance System. The initials, we call it BRFIS. That is a survey that is a collaborative effort between the Centers for Disease Control and our state health department. That survey is done annually in the state through telephone surveys. It's a telephone interview survey. And they telephone both landlines as well as cell phones. And the cell phone started in about 2000 and about 4 years ago, I believe, somewhere in that neighborhood, where they started adding cell phones to the BRFIS. It surveys between 6,000 and 8,000 South Dakotans annually, and it does a little bit of an oversampling to make sure there's a representative sample for Native Americans within that survey. This survey, and you can find it if you just put in your web browser, you look for behavioral risk factor surveillance system. You can go to the state health department, has some data sites related to it, as well as the Centers for Disease Control has some data sites related to it. Behavioral risk factor surveillance system is primarily, it's individuals 18 and above, and it primarily focuses in on health behaviors as a whole. So there's a lot of health and health-related questions in there, a handful of substance use questions, and a handful of mental health questions. But it's primarily a broad health-related survey. The National Survey of Drug Use and Health is supported by the Substance Abuse and Mental Health Services Administration, which is the parent organization to CSAP, the Center for Substance Abuse Prevention, which most of our funding comes from. And it is a in-person survey that is done with a it's a computer-assisted survey. So a proctor will go out to the targeted household, and they randomly select where they're going to be surveying people across the state. A proctor will go out, or a survey administrator, meet with the individual that's kind of the index or the primary individual that they're trying to reach within that household, and kind of assist them in engage in completing the survey online through a computer. So it's assisted that way. The proctor necessarily does not necessarily see the answers. They're there to assist. I believe participants are reimbursed $25 to $50. I don't remember exactly what it is. There's about 600 to 800 of these surveys done annually in the state. And through various statistical processes, they're able to generate very accurate statistical results on estimation of substance use, mental health factors, all those kinds of things across the state. This survey is done for individuals age 12 and above, and it's able to break the data into 12 to 17, 18 to 25, and 26 and over is how most of their data comes back, and their summary statistics. In some cases, they'll break it down by male and female, and in some cases, they will do, say, just 18 and over for some of the questions. And we'll get into a little bit more of that when we start showing some of the data. Probably the largest data set for us in prevention and coalitions is the Youth Risk Behavior Survey at a state level. This is for high school students, freshmen through seniors. It's done every 2 years. It's sponsored by the Centers for Disease Control in collaboration with our Department of Health, as well as our Department of Education also participates in this. It is done with a kind of a set of schools, usually around 25, 26, 27 schools annually spread out across the state. Not every classroom receives, or every person in a class, so they select certain classrooms that actually complete the survey. And it follows a sampling protocol developed by the Centers for Disease Control to make sure that survey is representative of our whole state high school population. There's been some challenges with this survey and other youth surveys in the past few years as a result of some legislative changes at the state level, that many school districts are interpreting those administrative changes within some of the laws to indicate that you must have active consent from parents for their students to be able to complete a survey. And what active consent means is that parents say, yes, my student may take or complete this survey. In the past, many of our schools used a passive consent approach, which was, please let us know if you do not want your student participating in a survey. So that has affected the ability to collect the Youth Risk Behavior Survey, along with some other factors. So we weren't able to have a data point for 2017 So you'll see in my slides in a little while that we were only able to have a data point through 2015. That data is really critical to us, and there's extra efforts in place to be able to capture that data, so we have a 2019 data point coming up here. And it's kind of important because we've seen a lot of changes within student behaviors, and there's a lot of things that have happened in the last few years that it really would be nice to really get get our thumb on the pulse of what's really happening in regards to some student behaviors in regards to substance use. The National Center for Health Statistics, that's where we can pull a lot of data in regards to morbidity and mortality data, and particularly, I mentioned earlier, liver disease. We can look at the trends in that data, and most of that data is coming, the mortality data is coming from the death certificates within the states and within the South Dakota State Department of Health. And another helpful one is looking at the Uniform Crime Report. That's through the Federal Bureau of Investigations, and you can kind of track trends in crime related to substances or other factors through that particular one. So at the state level, we have all of the kind of corresponding departments that we work with. So the Department of Social Services, that's where the Division of Behavioral Health is. They collect their treatment data through the STARS system, and so that can report back on the number of individuals that are entering treatment in the state, publicly supported treatment, money or programs that they support, as well as some of the other program data is available through them. Department of Public Safety, that's where our Office of Highway Safety is located, and they have impaired driving data related to substance, alcohol-related crashes, etc. Department of Health, I've mentioned a number of times, they have their the BRFIS data, and they also have some links to the YRBS data, as well as other kind of state indicators in regards to health across the state. And I'm going to share some of that in a little bit that links to substance abuse. The Unified Judicial System, that's our state court system. They have their data. They put out an annual report, and within there it's broken into each of the circuits, as well as within each of the circuits you can see the counties in terms of the number of filings for certain kinds of offenses. And that's just helpful to track on a county and regional and circuit level and state level some of the key aspects and consequences related to substance use. Department of Corrections also has some data on their site, and that's helpful because substance abuse is a significant component of those entering our corrections system as well. There are other data systems out there. There's the Census Bureau, which I haven't mentioned, which really gives you population-related data, and some of the other kind of community-related data in terms of number of households and poverty, and all those types of things can be pulled from the census data site. There's other local data from your that you can get either through your courthouse, and many of the courthouses may have that information online in terms of number of housing applications and different things like that. So there's lots of pieces of information that you can pull together to look at things. A real challenge is once you get to smaller communities, you can't necessarily drill down to a county or community level through many of these data sets. And so what you have to do is try to pull your community data as best you can, maybe through some focus groups or surveying or other ways, observational types of data, or kind of some of your local officials, and then put it in comparison with your county data that you might be able to obtain, your regional data with maybe a collection of counties or circuit, etc., or state level data. Kind of do that comparison. And that will help kind of shed a light on, okay, how is things looking within your community compared to our region, our county, our state, or the nation as a whole. Okay, so just a bit on our population and some demographics. This is the 2017 estimates. What I'd like to point out, we're at about 850,000 total within our state, 860,000 people. So we're a relatively small state. But what I'd like to point out is if you look at the proportions of our population and you look at it by race, the American Indian population is a much younger population proportionally than our white population. And that's just something to keep in mind when we're targeting prevention efforts in long term. I don't have on here other races because they're fairly small yet, but we are seeing a large we're really starting to see a change in a number of Hispanics, as well as other, kind of a mix of other immigrant types of population, particularly in certain areas of our state. Sioux Falls in particular has a large immigrant population, and is starting to really see a lot more diversity, and same with Rapid City. And so we're starting to see that demographic changes within our state, and over the next 10, 15 years, we're really going to start to see the spread of our population change by age and race and ethnicity. So this map is just, every dot that's on the map is approximately 100 people, and this is based on the 2010 census tracts. And what we did is we plotted the data just so that you can kind of see the diversity and spread of our data across the state, and our population. And you can see how it's really concentrated in the Sioux Falls area and in the Rapid City area, and then some of our other major towns. But then you have broad areas where it's just spread out very, quite wide spread of our population. If you're trying to do prevention, it's important to kind of understand where's your population located, how do you reach those rural areas, what are the challenges in the mix of our population, so that you can choose appropriate efforts to reach the population that you're targeting. All right, so now we're going to kind of move into some general health statistics. Are there any questions or anything up to this point? Okay.
I'm not
Jody,
seeing anything on the chat, so.
Okay, nothing in the chat box. I've probably put everyone to sleep by now. I hope everyone has coffee.
I did it beforehand, so.
Really, this is much more dynamic in person. I mean, and exciting, I have to say. All right. So let's talk a little bit about general health indicators at a glance in our state, okay? So this is from the report from the State Health Department 2015 or 14. They put out the data in kind of an annual kind of health indicators report the Department of Health does each year. I have not seen in the most recent reports this sort of summary table, so I have kept this in here. The numbers will change. You can still see those kinds of numbers in the other reports, and I have some other examples of that report in a little bit. But I've not seen the same table that kind of put it in a kind of a nice summary. And so I wanted to just share this because when we look at many of the key health indicators that in the state used to say during each day in South Dakota there were an average of, this was the average. Well, I have kind of put a target on there, a little diamond or triangle that kind of indicates all of those health indicators in which there has been research that shows some level of substance use or mental health, emotional research that links substance abuse and mental health to that particular indicator. And if you look at all of these, there's a significant portion of these indicators in which substance abuse and mental health plays a role in some fashion. It's not, remember, it's not cause and effect. Doesn't mean every single one of them is related to it, but a significant portion of those indicators or individuals affected are related. There is a thing called an attributable fraction, and that means how much of an indicator is attributable to a particular condition or cause. And I will just use accidental deaths. And what we do know, and I don't know the exact attributable fraction, we do know that for accidental deaths, a substantial portion of accidental deaths are related to some form of substance use. And so that's one thing you can you can kind of look at and think about. We do know that a portion of cancers are related to smoking. We do know that intentional self-harm and suicide, that a proportion are related to substance-related. The substance abuse and use played a role in a proportion of suicides. So that's why I think it's important to kind of understand that it doesn't mean all of them were caused by substance use, but a proportion of it, and in many cases a significant proportion are related to substance abuse and mental health related issues. This is kind of an updated report and kind of gives you a little bit of a glance. You can find this at the South Dakota Department of Health, and I have the link and information below. And it just kinds of, gives an update on some of those health indicators and the leading cause of death and mortality at a quick glance. I like to point this out because it's just another resource. And in this report, they also break it down by county. So there's usually is a county section at the back of the report that will allow you to look at your county. You may have a county or multiple counties that are of interest to you, and you can pull this population-based data from it. So one of the things I'd also like to look at is the leading causes of death by age group in our state. And so if you look at accidents by age, or you look at what's ranked number one by age, you see accidents is the leading cause of death for individuals age 1 through 39. And we know that substance-related accidents are a substantial portion of all accidents, okay? Then age 40 to 59 is cancer. And we know that smoking, and to some extent, some people argue that other substance use contributes to cancer as well. But cancer is the top ranked cause of death for those individuals 40 to 69. I'm sorry, 40 to 69. 40 to 79, actually. I'm sorry. And then you look at heart disease is the 80, 89, and 92 and over is the leading cause of death for those individuals. And you can kind of go through each of the ranks and kind of see, okay, is that cause of death related to substance use, et cetera? And you do see chronic liver disease creeping in there at the third leading cause of death for those age 30 to 39. And for those age 40 to 59, chronic liver disease is the fourth leading cause of death. And so it's you can kind of see, and then you can start to see where intentional self-harm starts to creep up there as the fifth leading cause of death it's the second leading cause of death for those age 20 or 10 to 39. And for those age 40 to 49, it's the fifth leading cause of death in our state. So just kind of something to keep in mind in terms of, well, what are we seeing from mortality in our state and the mortality statistics and the leading causes of death in our state. This just breaks it down a little bit more, so a little more detail for you to go through at some point. And this comes from a little bit older report, but one of the terms in epidemiology when you're looking at causes of death and the impact upon the population is the term years of potential life lost. You may often hear some of the statistics guru call it a YIPL. That is the what that is it's the measure of years of life lost before the age of 75. So, for example, in 2016, when we look at accidents and we look at the age of the individual that died from that accident, and then we look at the difference between their current age and 75, the age of 75, we add all that up, there was 11,921 years of potential life loss. That would be assuming if the accident did not happen, and that individual would live to the age of 75, and they chose 75 because it's kind of a median age for, kind of a life that they use as a calculation. But there are almost 12,000 years of life lost to individuals that died because of accidents in 2016. It's just a measure, and what it tells you is how much of a disease affects a younger population. And so you can see accidents affect a significant portion. Suicide, there were about 5,500 years of potential life lost as a result of suicide. So significant impact on a younger population. Okay. All right, now we get into some substance abuse related data and consumption data that we'll see. So this comes from, there's a report that's put out annually on the national basis that goes in and collects data from alcohol sales in the state. And it can calculate the amount of ethanol consumed or sold per individual per capita over the age of 21. So for legal drinking age, it calculates approximately how much ethanol in gallons from alcoholic beverages was consumed within the state. So the dark line with the solid dark line, that is South Dakota. And so for 2016, there was South Dakota per capita for individuals over the age of 21, there was about 3.2 gallons of ethanol consumed annually by each person aged 21 and over in the state. The national average is the dotted line down below, and that was at about 2.6 gallons. So we're above the national average. The little initials there, North Dakota is greater than us. Montana's greater than us. Minnesota, Wyoming are a little bit lower than us, and Iowa's a little bit is lower, and Nebraska's lower than us. But it kind of gives you an idea of how much alcohol is being sold and thus consumed or presumed consumed by individuals over the age of 21. So the real question is, how much is 3.2 gallons of ethanol per capita for individuals over age 21? Any guesses? How many cans of beer do you need to drink to reach that level of ethanol each year? Anything showing up?
You can either chat it in the chat box or else you can unmute yourself to answer. Want me to sing the Jeopardy tune?
Da, 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 da. Do they have to answer in the form of a question?
Maybe. Jeepers, nobody's answering.
Nobody's.
Yes. What is 10 cases?
What is 10 cases? Well, okay, 10 cases. All right, so 240 beers is 10 cases, right?
Yes.
All right. Well, let's do the math and find out. So 3.2 gallons of ethanol is about 409.6 ounces of ethanol, okay? Here's where it gets a little bit tricky, and you need to kind of think about, well, what are people actually drinking? So, a 12-ounce can of beer such as Miller Lite or Bud Light is about 4.2% alcohol by volume, okay? And so in each 12-ounce cans of beer, there is a little over a half an ounce of actual alcohol within that beer. Okay, everybody follow me so far? So then we take that 409.6 ounces of ethanol, which is equal to 3.2 gallons of ethanol, and we divide that by 0.504, or just a little over half an ounce. And that results in about 812 cans of Miller Lite or Bud Light. Now, there are different levels of alcohol or percentage of alcohol in different beverages, so you'd have to adjust based on the beverages. So based on that average, 812 cans annually is about 2.2 cans a day, or about 15.6 cans a week, so a little over a 12-pack a week. And that's assuming that every person over the age of 21 drinks alcohol in the state. Okay, at that level, that's a lot of alcohol. Any comments, thoughts on that?
I just told Chess that she had a really good guess at 10 cases, but it was way too low.
Yeah, it's a lot. So let's so what does this really mean? You know, what are the consequences of an average of over a 12-pack of beer per week? Okay, for our whole population. It's not everybody's drinking that much. So one of the things that kind of shows is DUI filings in our state. And so this comes from the Unified Judicial System and their annual reports each year. And it looks at the number of DUI filings. That's how many offenses there are for DUIs in the state that were filed with the court system. And so in the kind of solid maroon bar is our DUI first. That means that they were charged with the DUI first. Kind of the orangish bar is they were charged with the DUI second. The next bar is a DUI third, and then kind of the square dots down below, those are 4s and 5s. And then the triangle is anybody with a DUI 2 or greater, kind of all added together, just so that you can see those are multiple offenses compared to DUI first offenses. So annually, you can kind of see back in 2007 and 8, we were at between a little over 8,000 and just under 8,000, and then it dipped for a little while, and then in the last few years it started to go back up for our DUI first. So about 7,200 were reported as filings for DUI first in 2017, fiscal year 2017 for from the State Unified Judicial System. In addition, there were about 3,200 multiple offenses filed. That means a DUI 2, 3, 4, or 5 filed in 2017 as well. So, quite a few. We're looking at about 11,000, a little under 11,000 DUI filings in 2017. If you think of our population, that's a substantial number of DUIs within our population. Okay. The other thing that's interesting, and I haven't quite figured this out yet, and it's an anomaly we're looking into, is so we see a nice correlation in regards to our DUI 2s and 3s and 4s, or multiple offenses from 2007 through 2010, where you saw a decline in our DUI first as well as a decline in our multiple offenses. Then you kind of see the multiple offenses go up a little bit and then kind of stay fairly flat. But then our DUI first are starting to jump back up, and we're trying to figure that out. Now, one of the theories might be we're doing more enforcement, but we really started to do the enforcement, back in 2006, 7, and 8. We started to really do the saturation patrols and the checkpoints, etc. But we're going to look and see if there's a lot more enforcement going on. That's one of the things we're looking into. But other than that, we just haven't been able to figure out, why might that be the case? What are the issues? So just something to ponder and look at. And if you're working with a community, something to kind of look at within your community. What are your rates of DUI offenses, and what might be contributing to those offenses. Another consequence is alcohol-related offenses. Now, this comes from a national database out of the done up in New York, one of the universities in New York. It hasn't been updated for a while, but I think it helps bring home the point. We can look at our data within, the crimes and offenses within South Dakota, and we can see this in that. But this kind of brought it to a easier, understandable manner. So we have a larger percent of our offenses, those are arrests in our state, are related to alcohol, and they have a whole designation of those things. So it'd be DUIs, it'd be other offenses in which alcohol is the contributing factor. And we have been either the highest or the second highest rate of those offenses in the nation from 2003 through 2012. And they haven't updated this source book since that time. But our competitor for the top spot was always North Dakota. And we're very similar in terms of our patterns and our populations in the state. And so, it's a substantial contributor to our offenses, and alcohol is a significant piece. If you talk with your sheriff or your police chief or any of your law enforcement and ask them, I think you might be surprised at their responses in terms of what are the main causes of their arrests and the offenses and things that they deal with. This comes from our, another consequence is impaired driving crashes. And so the bottom line are alcohol-related fatality crashes that were reported in 2017 compared to those in non-fatal crashes. And so the one thing we do know that is if you're in an accident in which there is an individual, a driver that has been drinking, you have a higher likelihood or higher chance or probability of that crash being a fatal crash than those that crashes in which neither of the drivers have been drinking. Okay, so what's all this mean in terms of population for adults and youth alcohol consumption behaviors? And so some of this is going to draw on some of those national data sets to really speak to the consumption patterns. So based on the behavioral risk factor surveillance system, the red line is South Dakota and the lower line is the United States. And this is the percentage of adults age 18 and older in our state that report alcohol use in the past 30 days, at least one drink. And you can see it's been consistently, between 56 and 60% since 2011. And that is that is a significant proportion of our population. So about 55 to 60% report drinking alcohol on a regular basis. Now, remember we calculated that on average for everybody over the age of 21, we had about a little over a 12 pack of beer a week. Well, if not everybody is drinking, what does that mean and how might that change? So we really would have to go back and add, 55 to 60% into our equation to figure out for those adults that are drinking, about how much alcohol are they consuming. And it would be substantially more than a 12 pack. It'd probably be more like an 18 pack on average. The National Survey on Drug Use and Health also asks about current alcohol use in the past month. And this goes through, I see my title I didn't change. It should be 2016 through 2017 is the last data year. But they have an average and calculate an average of about between 55 and 60% of our population reports drinking on a regular basis. at least one drink in the last 30 months or 30 days. Sorry, excuse me. Binge drinking. Now, this is an interesting one to me. So we have been historically one of the top binge states in the country, usually in the top 2 or 3. Wisconsin and North Dakota consistently are up there as well. And binge drinking is defined as 5 drinks for a male and 4 drinks for a female. So about just under 20% of our population reports binge drinking on a regular basis. Okay. Now, adult heavy drinking. South Dakota is the lower line in this particular case. And this is where I think our population and understanding our kind of our culture, and why I say, I've always used the term we're a binge state, is really interesting. So heavy alcohol use is about 14 drinks per week for men and 7 drinks per week for women. And so nationally, what we have seen is, although their binge rate nationally isn't as high as South Dakota's, they've always been heavier drinkers. In terms of heavy drinking, percentages have been greater. And that is just the pattern of drinking. So nationally, a larger percentage of individuals report drinking, men report drinking on average 2 drinks a day, and women report drinking 1 drink a day. Well, in South Dakota, we have a lower percentage of individuals that report drinking on a consistent basis, but we have a higher percentage of people that report binge drinking. But what my concern on this data is, and I'm anxious to see the 2018 data when it comes out, is if you see, and I don't know if you can see my mouse here, but our trend in the last 3 years or 2 years has gone up with whoops, I didn't want to change there, with a larger percentage of our population starting to report drinking at least at a heavy drinking level. Meaning, in the past, the way most of our consumption patterns have indicated is that we had a substantial portion of our population that drank at a binge rate, meaning 5 or more for men, 4 or more for women. And I equate that to, men's night or women's night at the golf club, and then on the weekend. So, a couple of times a week they binge drink. Now what we're starting to see, and if this pattern continues, we're going to start to see a heavy alcohol use. That means we're drinking on a more regular basis. So instead of just a couple or 2 or 3 nights a week, we're having, drinks throughout the whole week. And it'll be interesting to see if this trend continues and what that means. Now, the big concern is, are people continuing to drink at that binge level on a weekly basis? That's going to have significant health consequences in the long run for our population if that becomes the case. So it's just something to keep our eye on and to watch. If we're changing from a binge state to a heavy drinking binge state, the alcohol consumption and the amount of alcohol in the bloodstream for a significant period of time, that's what creates health problems for people, as well as negative consequences, is going to have a significant impact on our population. Okay, here's from the National Survey on Drug Use and Health. They have questions built into that allows our population the calculation of whether somebody has an alcohol dependence or not. And you can see South Dakota, they're estimating that about 7.5% of our population has kind of fits the pattern for some level of alcohol use or disorder. And so, hey, Dodie, I saw my little box pop down. Was there something that popped up in the chat?
Not that I can see. No.
Okay. All right. Sometimes when it does that, that means that something.
Right.
So, okay. Just wanted to stop and see. I should stop and say, does anybody have any questions on some of my comments so far?
I guess one of my thoughts is for those who are working in the communities, you know, this is statewide data. How could you foresee them using this to get it to pertain to their area?
So what I would do, one of the things I think it's useful is this provides you statewide data, and on average, you can get some local data from your, say, if you're looking at DUIs or you're concerned about impaired driving within your community. You could get local data from your police department or your sheriff's office and work with them if they're willing to share it. And sometimes when it starts to, you have to be careful because you don't want identifiable data. But what might be interesting is to look at, okay, what is the BAC level of individuals when they are arrested for, on average, when they're arrested for a DUI, and what time of day was it? And through the calculators, you can kind of estimate, all right, when would that BAC level return to zero, and what time of the, when was that? When did that offense occur? And you could look at what I like to use as the example, and I pick on our golf course a little bit here, but I use the example of men's night. And I know most of those individuals and their consumption patterns, and I know what their vocation is the next day. And many are in heavy equipment, whether it be on farms or whether it be working for some of the businesses in town in which they're driving trucks and stuff. There is a substantial level of impairment in terms of alcohol in the blood system during the working hours during the next day. We did some calculations, and there is a kind of little brief I can send out, Dodie, that we could disseminate. That when some work I did for the Office of Highway Safety, and you're looking at 2 o'clock to 4 o'clock the next day before BAC returns to zero, based on some of the if you're looking at the average BAC in which individuals were arrested for. And I think at that time for that year, we estimated that the average BAC for a DUI was 0.17. And my point being is that, from that, you could gather some of that information locally and you could compare it to the state and national averages, and translate it into what does this mean for us locally and risk locally. And there's a substantial amount of liability risk for businesses, as well as health risks and safety risks for individuals in general population that are on the road. So that's one example. The other thing you could do is, kind of look at, and you can do questionnaires at different events and stuff, and just see, okay, last time you went drinking, what was your, how many drinks did you have? And you could, what's your age, gender, and, you could just ask that and have it anonymously. And when you add all that up, you could use it to say, okay, we did this survey at our booth at this particular community fair. And, for men, it was an average, last time they drank, it was an average of 4.5 drinks or whatever it might be. And, you could then calculate out, well, when's that BAC level going to return to zero if they stop drinking at 10 o'clock at night? Or you could, there's various different things you could do, and you could compare it to the national average for binge drinking, et cetera. How many individuals binge drank compared to the national average, and that kind of stuff.
Have you had any of your coalitions that you've worked with, have they done anything like a community, I know they do community like perception surveys in regards to youth, but have they ever assessed anything like you're talking about where they'd send out an anonymous survey about
Sure.
kinds of questions?
Yeah, some have at primarily at health fairs or those kinds of community events. They have done things like that in which they look at, just general population concerns and behaviors, et cetera.
Have you ever sent it out like on an online survey kind of a thing?
I think some have. Yeah,
Okay.
I think some have. Yeah. And I think you want to tailor it and you want to try to target, you don't, the biggest concern if you send out just a bulk survey without some kind of context to it is, people are, how can I phrase this? People are a little bit concerned about, you know, reporting or responding to questions about their individual behaviors if they
Yeah.
perceive you might be seeking them out. And so, you want to be careful of how you present that and how you disseminate that. And I'll give you an example. One of the projects I'm working with at the state level is called the SBIRT project, which is screening, brief intervention, referral to treatment. And that whole process is trying to work with primary care clinics to integrate screening for substance use, both alcohol and drugs and mental health, into kind of your annual checkup, your annual visit. And then if you screen high, then engage you in a brief intervention or appropriate levels of service if there's some other needs. But it's trying to normalize the conversation so that talking about alcohol, substance and drug use, and talking about emotional and mental health related symptoms becomes a normal conversation, just like having the conversation with your physician or clinician regarding your blood pressure.
Sure.
Trying to normalize that conversation, turning it into a health conversation and not into a siloed conversation about substance use or behavioral health or mental health. Trying to take away that stigma of that conversation. I think, in my opinion, that's something we really need to work on, is normalizing that conversation and creating that that it's, and linking it to, it's a health conversation. It's not an accusatory conversation about your behaviors. Ironically, when we were first starting this off, and we met with a number of the physicians after we'd ran it for a while and had some conversations, and it was a little, bumpy road getting it in place and starting in many of the clinics. But when we met with someone, we had a site visit. When we met with some of the physicians and we're talking about that with the feds that were in with the site visit, a couple of them were brutally honest and said, well, I have a hard time asking my patients these questions and doing this, because if I filled out this questionnaire, I would have fallen into the high risk category and, be needing a brief intervention from last weekend. And so, it's changing that conversation, the tone of that conversation, so that it's not an ashamed conversation or a stigma-based conversation. It's a health conversation in a positive manner and not a judgmental conversation. And many of the physicians and clinicians also report, it's like, I've known these patients for 20 years. I know they drink at a high rate. I don't want to now screen them and start accusing them of drinking at a heavy rate. And so it's going to take a long time to change that norm and that conversation and that thoughts about, how do we view alcohol use? How do we view substance use or mental health related issues? And that, that also, Dodie, brought up a thought, some of your other partners within the community are your healthcare providers. They, if they are doing screening and brief intervention work, or they're doing screening within their clinic, where, say, alcohol, tobacco use, other drug use is a common thing, they may be willing to share with you, this proportion of their patients report heavy alcohol use or something along those lines. Okay. Other questions? Thoughts? Anything else you see, Dodie?
Yep. Juanita just said our reservation has little data on other substance use other than alcohol, but the communities, 9 of them that are concerned of meth and opioid use.
Okay, I'm trying to get to my chat so I can see the full thing. You were a little muffled on your. Okay, how do I get to my chat? It's not letting me do. I'm afraid if I do that, I'm going to lose my sharing.
Like if you go down like toward the bottom of your screen, it should pop up that you need to click on chat bubble.
Yeah. Since I'm in present mode, it's at the top of my
Oh,
screen, and I don't.
okay.
Um, trying to figure out how to. I normally use a different online system, so I'm not as familiar with how to with
So
Zoom.
basically what she's saying is they have data on alcohol, but not on meth and opioid.
Okay, so they have data on alcohol, but not on meth and opioid.
Yeah.
Um, so the best, what I would suggest is a couple of things they could do. First, you could look at. Whoops, I went to the. Okay, hold on a second here. I've got
I'm
crazy
not
stuff.
sure what's going on, but your screen got really fuzzy on my end. Anyway.
Yeah, and I'm not sure what I was trying to get to the chat mode. You know what? I'm going to stop sharing and I'm going to just reshare again and get out of this. Okay.
Okay. Yep.
There. Is that better?
No.
No. Oh. How about that?
Yes. That's good.
Okay.
Yeah.
All right. Okay. So to kind of respond to the those questions, the couple of things you can do. You could first, I think, develop the relationship with your emergency room just to see, okay, and they may not be willing to share, and it's a difficult conversation at time because of confidentiality. But what are they seeing for individuals coming in that might be suspected of having opioid overdose or whatever it might be related to opioids? And the same with meth. The same conversation can happen with your sheriff's department. I had an interesting occurrence where I had to be in the sheriff's office for an issue, and was sitting there. I was having a well-being check done on a family member, and so I was in his conference room visiting with him and stuff, and while he was sending folks out to do this well-being check, and we were talking, and while I was sitting there, he had no less than 2 or 3 phone calls that he had to excuse him for because of substance abuse related behavioral issues going on within the county. And, while it doesn't give you exact numbers that are hard, that you can say this many occurred, et cetera, and they may be able to give you some exact numbers, having those conversations about how big of an issue is it? Where are you seeing issues? How many times do you go out because there are substance use? Maybe it's be meth or opioid or whatever, other drugs. What are the issues that you're responding to as a sheriff's office? And that'll give you a pulse within your community. All the sheriffs that I've been at and many of the coalitions that have sheriffs involved, it's amazing the different stories that they have, and they can say, yep, about 80% of our things have some degree of substance abuse involved, or maybe 60% or something. But their perceptions and what they're dealing with is critical. And now, granted, that's on the consequence side, but then you can kind of work backwards and figure out, okay, what's really happening in the community? How can we address these issues? In terms of opioids, there is the prescription drug monitoring program in the state that's run by the Department of Health. And it's a board of pharmacy that actually runs that. There is data that's available on the county level historically on the number of prescriptions and the quantity and the days of supply that were provided on an annual basis. by county. Now, they may have some restrictions on how they release that for smaller counties, just to make sure that it's not identifiable. You can also look at, some of those conversations could occur with some of your physicians in town, and that's also a challenge too, because some of the physicians for years, and I don't know if you've been following some of the opioid-related lawsuits in the country, many of the pharmaceutical manufacturers that provided opioids really pushed these drugs and marketed them slightly, maybe unfairly, to physicians. And so physicians were responding to the information they had at the time and prescribing these. And some physicians and clinicians feel a little bit of, they're a little bit concerned, because for years they're telling their patients one thing and prescribing these pills, but then all of a sudden now the new information is coming out showing how highly addictive they are, and that's contrary to the information they were given a while back when they made their decision to prescribe. So that's a challenging conversations, and many of those prescribing practices are starting to change. But it just is a way of trying to get a pulse on what are the issues in the community. If you have a treatment provider within your community, you could look at, what percentage of your treatment admissions from your community or your county are related to which drugs. That's another indicator to look at. You kind of have to piece together various factors to kind of really look at what's the real picture for our community. And also community surveys in terms of what are your concerns? What do you think is the big issue for our community? Those are important as well, to reach out to find out what are the real concerns in regards to substance use behaviors within our community.
So one other question that came up from Chessa is, where do you get the prescription drug county data?
You would have to contact the Department of Health, Board of Pharmacy, the South Dakota PDMP, and you can find it online and see if they will provide that information to you for your county. It's called the Prescription Drug Monitoring Program. I can get the web link if somebody wants that. You can see the state statistics, and then you can see whether or not it would be available on a county level for you.
So is it going to look any different if it's for reservations?
Yes.
that was Juanita's original question, was she's on the reservation and
yes,
trying to get that info.
So I've actually done some work on this, and it's not published yet or publicly available. And I've looked at reservation counties compared to bordering counties compared to non-reservation counties. The rate of prescribing for reservation counties and those bordering reservation counties have a much higher rate of opioid prescription access and availability over the last few years. Now it's been declining, but those have a much higher rate than non-reservation counties. I did some additional research in regards to that, and there's some research out there in regards to Medicaid patients, and this isn't Indian Health Service patients. I'm just using Medicaid patients as a whole. But there's some research that I found that points to a higher level of prescribing within the Medicaid population of opioids in the past. And basically what my concern was, well, did we see the same level of higher rate of prescribing of opioid within the Indian Health Service? And based on my initial data, that's what the initial data is pointing towards. And sort of the concern is that, okay, it's a, very, very busy, heavily, scheduled, limited number of practitioners trying to serve a significant population. and so they're trying to find quick fixes for getting the to addressing the patient's needs, and that's a little bit of the explanation that was in the Medicaid article, and so you'd see higher rates of opioid prescribing. Now, what we have seen is we've seen a decline in those populations in terms of the percent of opioid prescriptions and availability of opioids within the population. The challenge is for those individuals that have been using opioids for years, how do you effectively, humanely, and transition those individuals to a better medication and regimen of medication, et cetera, to manage their pain. And that's really important because all of a sudden, if you just cut off the access to opioids, what you have seen, and we have seen in the data from, say, Massachusetts truly saw this, is a huge spike in the use of heroin. And so you have, and then you have all the other issues that come along with heroin usage. So that's something that I think that's important to look at, and how do you actually do that effectively? Another source could be your pharmacist too, to talk about, okay, what are you seeing from your perspective? They cannot tell you what they can't tell you for patient confidentiality, but in general, do they see concerns in the community? Is it widespread? Are they having a lot of patients that are trying to seek opioids, et cetera? We had some issues in our community. Our pharmacy was broken into, I believe, once, maybe twice, to get opioids. We had other things happening within our community where homes were being broken into to get opioids and prescriptions from individuals that they knew had just had surgery, various different reasons. Any other thoughts or comments?
So a couple. Dr. asked if you could send the web link for the
PDMP. Yep. Okay.
Yep. And then
I can do that, Jody. I can send that out to you. So
yep.
After this, I think there'll be a number of links we'll want to send out to everybody.
Okay. And then Juanita was wondering if she could get the data information or research to help with her conference that she's having.
Okay, I'm sorry, I couldn't get all that, Dodie.
She wants the data information or the research to help with the conference that she's having on the reservation.
Okay, we'll tell you what. Let's. I think we'll need to do a follow-up conversation with that, since I'm doing that underneath another project for the Great Plains Tribal Chairman's Health Board. So,
okay,
let's get that information, and so Juanita and I, so we can connect.
Yep.
And handle it appropriately.
Sounds good.
As that's that, it's data that's publicly available or can be requested. I was doing that work for the Great Plains Tribal Chairman's Health Board, so I want to circle back to them and give them their due credit and respect. So,
all right,
excellent. Okay, I think I'm going to move on here, and I need to just give me a second here. Okay. I think we talked about heavy drinking. Now, why is my computer not moving? There we go. I think we finished on alcohol dependence. All right. So another source of data, and this all kind of leads into this, and I'm kind of lucky that we were at where we were in this, is, and it's starting to be a little bit dated, but the Helmsley Foundation did a behavioral health survey a few years back, and that behavioral health survey looked at substance use, mental health related issues, access to health care, and they surveyed about around 7,000 households. Don't quote me on that. I'd have to go back and look at their report to know for sure. But that data is available, and they have county profiles in the back of their report that provides that information. Within their survey, they embedded valid and reliable screening tools for alcohol misuse, severe alcohol misuse, and for binge drinking. And you'll see later on they had some mental health tools in there as well, and so we'll talk about them in a bit. So I went to their survey and I had pulled out, what they found within their behavioral health survey. And so they found that 42.4% of the individuals surveyed identified or reported their alcohol consumption patterns fit into a misuse category, alcohol misuse. Almost 12% fell into severe alcohol misuse, and about 19% fell into the binge drinking category, okay? Then on some of our prior slides, I talked about what the BRFIS found for 30-day alcohol use, and it was about 55 to 60% had reported alcohol use in the last 30 days. And based on the BRFIS, about 17 to 18% binge drank in the last 30 days. And from the National Survey on Drug Use and Health, we found about 7.5% had some level of alcohol use disorder in the past year, okay? And then from the National Survey on Drug Use and Health for the last 3 years, right around 58 to 59% report consuming alcohol in the last 30 days. So based on these three data sources, I can say with a lot of confidence for our whole population, adult population, and to some extent it's individuals, high school students included as well, because they are included in at least one of the surveys. We know that our adults and our 12 and older population from the National Survey on Drug Use and Health, 60%, almost 60% drink alcohol on a regular basis, at least within the last 30 days. Okay, and we know that from two sources. We know that from the National Survey on Drug Use and Health, and we have very similar data coming from the Behavioral Risk Factor Surveillance System. We also know from these different data sources that binge drinking is, and we have two data sources that confirm binge drinking is at around that 18%, 18 to 19%. The Helmsley Foundation found that indicator to be about 19%, and the BRFIS data consistently shows that between 17 and 19%. So from two sources, we know that our binge drinking is just under 20% of our population binge drinks. We also know from the National Survey on Drug Use and Health that they report about 7.5% have some level of alcohol use disorder in the past 30 days. And the screening alcohol misuse from the Helmsley Foundation was just under 12%. And then just general alcohol misuse, we see at about 42% from the Helmsley Foundation. This is in our general population. This is our communities, our neighbors, our, just our population as a whole. Those are pretty profound and reliable and validated numbers that we can say with a lot of statistical support behind them this is what alcohol consumption looks like within our state. Make sense? Okay. Any questions? I should say that. I'm saying make sense and looking for heads to nod, and that's not going to happen right now.
I don't see anything in the chat box, so.
Okay, great. Hopefully that little tirade of mine was gives you some nuggets and solid pieces of information and understanding of what alcohol consumption patterns are like in our state. Okay. All right. I've talked a lot about population data. Just a little bit on youth data, because that's very critical for many of our coalitions and prevention activities. Our youth data primarily comes from the Youth Risk Behavior Survey. And this survey, as I mentioned, is done within high schools, 9th through 12th grade. And it's been done consistently since 1991. And you can see, and this is the greatest evidence that there is for prevention activities. We had about 60% of our student high school population reporting that they drank alcohol in the past 30 days in 97, 99. That consistently dropped to about 28% in 2015, which is the last data point we have. And again, this is a survey in which they weren't able to survey for a 2017 data point. We didn't have enough sample. We'll have hopefully another data point 2019. Okay. And so around that time, 1997, 99, and particularly again in 2005, 2007, there were substantial efforts put into prevention within the state. And it really shows that talking about alcohol use, prevention activities related to it, you can really decrease alcohol consumption. This is the same data source, but now it's talking about binge drinking. And you can see how we were able to really decrease the binge drinking within our state. Ever drank, this is individuals reporting ever drinking in the state, and same thing. Okay. One last thing about the alcohol consumption within our high school students. I'm very, very concerned about, how different availability of different types of alcohol will affect our population, and particularly our high school students. A while back there were the alcohol pops. There's some push for some alcohol infused or hemp or marijuana infused beer, various different things. And so I think that's key to monitor the different trends in alcohol beverages and what that means for accessibility for our youth, and where youth might be able to obtain their alcohol. Okay. All right. So now some data related to drug and marijuana. So this comes from the National Survey on Drug Use and Health, and it shows they estimate that about a little over 7% of our population report using alcohol in the past month, compared to just under 9% nationally. The trend is up. It's been a consistent trend up for the nationally, and overall trend for South Dakota is up since 2009, 2010. Something we're just going to need to keep an eye on as the push for legalization continues. This is how our high school students report alcohol use. And this is currently used marijuana, which is essentially using marijuana in the last 30 days. And in 2015, about 12% of our student population reported using marijuana in the last 30 days, compared to about 21% nationally. Again, going to be very critical to see where are we at when we get that next data point for our youth at a statewide basis. Ever used marijuana, and this is reporting ever used marijuana in their lifetime, we're at about 25% compared to almost 40% nationally. And again, that next data point is going to be very critical to see, okay, where are we at? Any illicit drug dependence or abuse in the past year. And this comes from the National Survey on Drug Use and Health. And about 7% of our 18 to 25-year-olds reports using some illicit drug and having drug dependence or abuse in the past year. Okay. And this is current illicit drug use other than marijuana. Now there are some changes in the survey, and that's why you have a little bit of a gap in the data set there. And it shows South Dakota compared to, and this is other drugs other than marijuana. And it shows a little bit of a lower rate than the national average, but not too much, just slightly lower than the national average. So a little over 3% report using some other form of illicit drugs other than marijuana. Okay, there's a discussion on methamphetamine, and this comes from the SAMHSA's treatment episode database. The data from our Division of Behavioral Health, the treatment data, when they have admissions, they report into this national treatment episode data set. And the last data available that I was able to analyze so far is 2016. And you can see in 2016, the number of treatment admissions in which meth was identified as their primary drug was 1,826 in 2016. I've been told that that trend has continued. Some of you remember that we had a big spike on meth use back in the mid-2000s, 2006. We really put a strong effort into prevention, and we're able to push that down for a few years, but then it started to creep back up, and we're seeing it spike again in 2016, and I guess 2017 is even higher. I took the same data, but I pulled in data from surrounding states, and we put it on a per 100,000 population basis. The reason for doing this was to see, are South Dakota experiencing the meth epidemic any differently than our surrounding states? And all those kind of lighter lines are our bordering states. And they are similar trends to South Dakota, all seeing kind of a dip in 2007-8 and a little bit of a plateau for 2009 and 10. It starts to, and 11, it starts to go back up and continues to rise for all of our neighboring states. Thus, it's a regional problem and not just a South Dakota problem in regards to our methamphetamine treatment admissions. And this is using treatment admissions as kind of an indicator for meth use within the states. This is meth use reported by high school students, and again, 2015 is the last data point we have. And so we had about just under 4% of our South Dakota students report ever using methamphetamine at least one time in their lifetime. Again, the 2019 data will be critical to see. Okay, this is the opioid information. It's again is treatment admissions. So in 2016, we had 420 treatment admissions related to opioids. 327 of those were non-heroin opioids or synthetics, and 93 were heroin. Now, opioids is a very interesting I'll just say addiction and pattern. This is not the typical population that our treatment and our prevention efforts have targeted, and it's a very different population and a mix of a population that we just haven't engaged in the past. For the most part, many of the opioid folks are individuals that have insurance. They have other resources in which to obtain their opioids, etc. It's just a very different dynamics. And so it's something to keep in mind. I like to use the terminology of the iceberg, or the analogy of the iceberg. And with an iceberg, you can see what's above the water. You just don't know how large it is below the water. And for many of our substance use related problems, that analogy holds true, but it is very, very appropriate to think about it in terms of the opioid epidemic and what's happening in regards to opioids in our state. We can see those that come in that have overdoses or that enter our treatment program, but there are so many more out there that are kind of below the waterline that they're either managing their addiction or they're seeking help that doesn't show up within our treatment data set, various different things, or they haven't reached the level of where there's a consequence that would put them into some kind of situation where they would be identified as having an opioid addiction. So I think that's something to keep in mind within the population, and as we kind of move forward in regards to this opioid epidemic. That's why it's very important to engage all of the stakeholders that you can, and having that conversation and really forming a coalition around substance abuse related issues. And opioid really brings that to the forefront, because you have all kinds of people that are involved or have little pieces of it or little snippets. You may not know exactly who's using, but you do see some of the patterns within communities. Here's the trend in the opioid use. I did the same thing for states, and I put it on a per 100,000. Our neighboring states all had a similar one. Ours is the kind of the orange line, and you see very similar. There are a couple of our neighboring states that had a higher bumps than we did, but the trends were very similar. And this is our high school students and what they reported for using prescription drugs without a doctor's prescription. And we had about 13% reported doing that. Now, the challenge is was not specific to opioids. This may have been some other kind of medication, like an antibiotic or something else. But it's just kind of one of those placeholder indicators for looking at using prescription drugs without a doctor's prescription. Okay, I'm going to switch to behavioral mental health related indicators. So the Burfus asked about ever been told of having depression, and about 17, just under 18% of our population report having been told that they had some form of depression. So almost 20%. And from our youth risk behavior survey, it's asked ever felt sad or hopeless, and we see about 16% of males saying that they had, and about 35% of females in the last data point indicating that they felt sad or hopeless among our high school population, females among our high school population. Suicide-related data. We have in South Dakota a very high suicide rate compared to the national average. In 2017, it was about 22 deaths per 100,000, compared to a national average of about 14.5%. Montana and Wyoming had higher rates than us. North Dakota just a little bit lower, and Iowa and Minnesota and Nebraska were all very close to the national average. But suicide affects our population, different portions, different segments of our population differently. This comes from the South Dakota Department of Health monograph on suicide they put out in January 2017. This is the trend in suicide rates per 100,000 by race, and the white race had about a rate of about 15.8 per 100,000, where you can see the huge jump in the American Indian, Native American suicide rate of it being almost 65 per 100,000 in 2015. And then other races was at about 41 per 100,000 in 2015. This comes from that same data source done by the Department of Health. And this is it looks at the suicide deaths over the last basically 10 years from 2004 through 2015. And it brings in age and race together. And it's a much younger population of individuals that committed suicide that were Native American compared to the white population. The white population starts to rise around age 13, 15, and rises till about age 21, 22, 23, and then stays fairly steady until around age 60, where the Native American population jumps up right at age 11, 13, stays high till about age 25, where it starts to dip down. It bumps around a little bit, but then it starts to decrease. So much younger, many more Native American victims of suicide were much younger compared to the white population. This is a little bit dated. I did not see this data updated within the most recent monograph by the Department of Health, but this comes out of the South Dakota Vital Statistics records, and the inpatient and and outpatient data collection system. And this just speaks to the mode of suicide and suicide attempts by gender. And if you look at suicides that are completed for females, you have about almost 40% by poisoning, about 33% by hanging, and about 22% by firearms. For females, for attempts that were not completed suicides, you had about 85% of poisoning and about 10 to 11% that were cutting. Okay, and then you have a small fraction of a few others. That differs from males, where about 52% of completed suicide in males was by firearms, about 11% by poisoning, and about 32% by hanging, and then a handful of others. Male attempts that were not completed suicide, you had about 75% poisoning, a handful of hanging, and just about 13% cutting. The major difference is, female, you have more males using firearms compared to females, and more females are completing their suicide attempt or committing suicide by poisoning than males. So you just have a little bit of difference in terms of gender in those attempting and completing suicide in terms of the mode. It's important to kind of understand that when you're looking at prevention, particularly when you're looking at prevention efforts for individuals that have suicide ideation. This is suicide method by age group, and just breaks it out even a little bit more and allows you to look at the mode by different ages.
Roland, Juanita asked, and it was a couple minutes ago, was that all the tribes together?
This one, or?
I'm not sure which one.
Probably this one.
I missed it, sorry.
Yeah, this it was probably coming from here in regards to American Indians. And this would be all the American Indians and Native Americans from that committed suicide in 2004 through 2015 combined. It's not broken out by individual tribes. Hopefully that answered the question. This does break out the uses that same 2004-2015 deaths by race, and so you can see a little bit of the differences in regards to mode of suicide by race as well as by gender. Kind of similar to the slide I showed previously, but breaks it out a little bit differently. So one of the things to kind of get at suicide ideation is to see what level of ideation is in the population. And so you have from the suicide or the Youth Risk Behavior Survey, you have about 16% of our high school students report seriously considering attempting suicide in the past year, compared to about 17% for the national average, and that's in 2015. And then made a plan, and you can see the differences by males and females, and this is only the South Dakota group. So about 16% of our females had made a plan of how they would commit suicide, compared to about 7% of our males. All right. Just one thing of why it's this is just an example of why it's important to look at co-occurring issues, mental health and substance use. And so this report came out from SAMHSA about a little over a year ago, about almost 2 years ago now. And it looked at the overlap between serious mental illness and opioid misuse. And essentially the takeaway from this was about 1 in 8 past year opioid misusers also had a severe mental illness in the past year. and alternatively, about 1 in 7 adults with serious mental illness in the past year had been past year misusers of opioids. So there's an overlap between, and this shows kind of how you can start to think about co-occurring conditions among individuals, both substance use and mental health related concerns. So I think it's important to think about what is that overlap? Why are people, and it gets back to some of my earlier comments in regards to why are people using prescription drugs, or why are people using alcohol, etc. And it is a serious consideration, and some people are self-medicating, etc. So just something to keep in mind. All right. In regards to mental health indicators, I did the same thing for mental health indicators with the Helmsley Foundation as I did with the Behavioral Risk Factor Surveillance System and the National Survey on Drug Use and Health. So what we can say from the Helmsley Foundation is based on an actual screening instrument embedded within their system, they had just under 6% reported some form of depression. They also indicate that about 17% had or were told they had some form of depression as a diagnosis at one time. That's very comparable to what the BRFIS has been reporting in Ever Told You Had a Form of Depression, where they are reporting 16 to 17%. So very consistent. You go down and you look at the National Survey of Drug Use and Health. Those are the 3 bars on the bottom. For the last 3 years, the National Survey of Drug Use and Health has reported about just under 18% had some form of mental illness, any form of mental illness in the past year. And the National Survey on Drug Use and Health has reported that just under 7% for the past 3 years have had some form of a major depressive episode in the past year, which is very consistent with the Helmsley Foundation screening, identifying just under 6% of depression. So, we have a lot of congruency between these 3 different data sources regarding mental health indicators as well. And earlier I shared the congruency between these 3 data sources in regards to alcohol consumption. This shows the same thing in regards to mental health, very consistent. So we can say about 17% of our population has had some form of depression where they've been told or diagnosed with it. We can say about 7% of our population has had a major depressive episode in the past year, and about 17 to 18% of our population has had some form of mental illness in the past year. So substantial portion. And if I wish I had some way of overlapping this with our alcohol consumption patterns as well as our drug use patterns. And so essentially somewhere in the form of 17, 18, 19, 20% of our population has mental health related issues. We also have a substantial portion of our folks that have substance use related issues. Therefore, it's really, really important to begin normalizing that conversation, destigmatizing the conversation regarding substance use, regarding alcohol use, regarding drug use, regarding mental health related concerns, and turning it into more of a health proactive conversation, because it is a large proportion of our population that are affected by both substance use and mental health. And then we start thinking about family members that are part of it's a much even a greater population of our population. So hopefully that is very helpful for you. I'm sorry, I meant to delete this slide. I was just going to talk about some of the key indicators to think about. And, I've covered most of them. The key ones to look at is current alcohol use, which is 30-day alcohol use, binge alcohol use, and perception of harm from substance use, and say perception of harm from binge drinking. And you could look at those 3 things for any substance. And I think those are the key things to begin looking at. So in your population, how frequency or what's the prevalence of people using that substance, whether it be alcohol, drugs, marijuana, opioids, tobacco, e-cigarettes. How, at what level do they use them? Are they binge drinking if it's alcohol? Are they using cigarettes at, say a pack a day or whatever it might be? Are they using opioids on a regular basis? Are they smoking on a regular basis, smoking marijuana on a regular basis? And then what is the perception of harm from substance use regarding, whatever substance it might be, whether it be alcohol, whether it be tobacco, marijuana? Is there a perception that those substances are harmful, and do they understand what the harmful nature of those substances are? What we have seen over time as marijuana has become more normalized, legalized, we have seen a decrease in people's perception of harm, meaning more and more people are thinking, oh, marijuana is not harmful. It's a natural substance. It's helpful for people that have cancer or various other diseases. And so they're not perceiving it as a harmful to individuals to be smoking marijuana. Not as many people are seeing it as being harmful. Well, from a prevention standpoint, if we know that people's perception of harm from a substance, if they don't have all the facts about a substance, and they don't perceive a substance or use of a substance as harmful, that begins to normalize that use more in the population. And so one of the things we can do is provide better education, enhance people's understandings of how does a substance truly affect the body and their health. And so that they have accurate information for making decisions and forming their opinions. The other thing is that you can look at is what are peers' perception and what are parents' perceptions of use of substances, et cetera, and health behaviors. So those are kinds of the main things to think about when you're looking at data and trying to make decisions about what's the best thing to do to help our prevention efforts within our communities. Are there any questions, thoughts, comments?
Well, there was one question I asked with PFS, and I typed it in the chat box. Partnership for Success is the grant that we've had from the feds, the state has had from the feds the last 5 years. It was kind of the continuation of the state incentive grant that was the 5 years before that. So, and it's to address underage drinking.
And I'm trying to get so I can see the comments. Here we go. Now I can get to the chat finally. Okay. Oh, okay. All right. So it was responding to the Partnerships for Success. Yep. What is that? Okay. Yep. Yep. Excellent. Other thoughts? I can't believe I've been talking for 2 hours.
Right.
At least you guys are close to home. You won't fall asleep on the way home because.
So what we will do is I'll get the links from Roland and I will send them out to all of you, and then I'll have the contact information there too. So then, like, Juanita, if you want to reach out and contact Roland with your questions and collaborate with him, that would be great. And then we have next week at the same time, same location, and I believe the topic is suicide prevention, I believe. So we will send the information out for that. That draws closer as well.
Great. Well, thank you, everyone, and I wish you all luck.
All right. Thanks, Roland.
Thank you.
Have a good
Bye.
night. Bye.